Okay, so we've got everybody here. I think we're ready to call the meeting to order. So I'll go ahead and call the meeting to order. If you'll stand with me for the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Thank you. And Cheryl, can you call the roll, please?
Yes. Director Nicholson?
Present.
Director Yee?
Present.
Director Stewart?
Present.
Director Epen?
Present.
Director Wallace?
Present.
Great, thank you. So welcome to the May 12, 2021 regular meeting of the Washington Township Healthcare District Board of Directors. To comply with Alameda County's order number 2101 as issued on January 25, 2021 to comply with social distancing measures and other restrictions necessary to control the spread of COVID-19, this meeting will be conducted by Zoom. I ask that you please mute your system until such time as you need to speak. Governor Newsom's Executive Order N2920 explicitly waives the Brown Act provision that requires the physical presence of members, the clerk, or of the public as a condition of participation in or quorum for a public meeting. We continue to comply with the Brown Act in providing dial-in information in order to provide the public the opportunity to attend the meeting. Public notice for this meeting, including dial-in information, has been posted appropriately on our website. We are recording tonight's regular session of the board meeting. It will be posted on our website for future viewing. Cheryl, if you could introduce the members who are present in the boardroom.
Kimberly Hartz, Chris Henry, Stephanie Williams, Ed Fan, Tina Nunez, Paul Kozachenko, Nicholas Kozachenko, Shri Bodu, and me, Cheryl Renaud.
Great, thank you very much. You got a full house there. So
Yes.
we'll move on to the oral communication section of our agenda. Members of the public are invited to speak during oral communications. When prompted, please state your name for the record, then proceed with your statement not to exceed 3 minutes on issues or concerns not on the agenda and within the subject matter of jurisdiction of the board. Are there any members of the public who would like to speak at this meeting? Hearing none, we'll go ahead and move on to our consent calendar. The consent calendar consists of those agenda items that the board will approve with one motion unless either a member of the board or a member of the public requests to remove an agenda item from the consent calendar. If any items are removed from the consent calendar, the board will take action on the removed agenda item later in the meeting under the action item heading of the agenda. Does anyone on the board want to remove an agenda item from the consent calendar? Hearing none, does any member of the public want to remove an agenda item from the consent calendar? Hearing none, may I have a motion to approve the consent calendar items A and B?
Mr. President, I move for the approval of the consent calendar A and B as presented.
Thank you. Do we have a second?
I'll second.
Second from Director Yee. Thank you. And Cheryl, can you call the roll, call vote?
Director Nicholson,
Aye.
Director Yee,
Aye.
Director Stewart,
Aye.
Director Epen,
Aye.
Director Wallace.
Aye.
Great. The consent calendar passes unanimously. Okay, so now it's time for our presentation. And Kimberly, if you could introduce our speakers tonight.
Yes, it's my pleasure to introduce our two speakers, and then I'm also going to turn it over to Stephanie Williams, our VP and CNO, to make a few comments too. But I will start with the introduction for Brenda Brennan. Brenda Brennan received her nursing diploma from Little Company of Mary Hospital in Chicago. her BSN from Chicago State University, and her master's degree in nursing from UCSF. Brenda started her career at Washington Hospital in August 1987 as a registered nurse in the emergency department. In February of 1989, she assumed the role of clinical nurse specialist for the emergency department. In 2014, Brenda Brennan was promoted to the position of emergency services administrator. In this role, she had responsibility and accountability for the overall strategic and operational planning and provision of patient care for the ED, observation unit, and future trauma services. In July of 2017, she was promoted to Assistant Chief Nursing Officer with responsibility and accountability for ED, nursing education, and magnet redesignation. Brenda has been at Washington Hospital for 33 years and has been very active in many institutional initiatives, including but not limited to disaster preparedness, lean implementation, and COVID-19 pandemic response. Next, I'd like to introduce Adelito Tanaco, who is a registered nurse with a PhD and Master's of Science degree obtained from the University of San Francisco in 2016. She began her nursing career at Washington Hospital as a new grad on 3 West. She holds an adult gerontology clinical nurse specialist professional certification. Adelita has grown professionally during her time at Washington Hospital. In 2018, she was med-surg and dialysis clinical nurse specialist and has now expanded her role as the magnet project manager. And tonight, everyone will be hearing about our journey along magnet redesignation. And we're very proud to be a magnet hospital and to learn about what that really means and our focus on nursing excellence. And we're one of 8 in the Bay Area who are magnet hospitals. So I'm going to turn it over to Stephanie to say a few words. And Stephanie Williams is our Vice President and Chief Nursing Officer.
Sure, thank you, Kimberly. As many of you are aware, magnet is a designation held by a small percentage of organizations. Washington Hospital, as you know, has been magnet designated for going on 12 years now. The journey to magnet has really served us well. Our nurses are highly educated, they are collaborative, and they are resilient. The structure and the processes that we have put in place have really served as a foundation for us to successfully navigate the move to the Maritime Pavilion, which we did a couple of years ago, and the pandemic. I think being magnet is about nursing excellence, but it's really truly about collaboration with the organization. It's all of us working together as a team. As we have heard before, it certainly takes a village. And in this instance, it does take a village to be magnet. And with that, I will turn it over to Brenda.
Brenda, you're on mute.
There we go. I followed directions in the beginning. Thank you, Stephanie. Thank you, Kimberly. Thank you for the opportunity to present tonight about our magnet designation journey. I'd like to mention that Adelita is new to her role as the magnet program director, very skilled in research and data interpretation, and took the challenge to submit the document on time, even though we had the opportunity to delay because of the pandemic, at a time when the village was busy managing the pandemic resources. So thanks, Adelita, for all your hard work and your efforts to pull this together and all the preparation that we're doing. Next slide. Or do I?
Brenda, yeah. Do you want to share it? I can share it right now.
Oh, go ahead. Can you share? Okay, Shri. Perfect. Thank you so much. All right, next slide. There we go. So, you know, it's only appropriate to talk about magnet redesignation at the same time that we're celebrating nursing. It's the International Year of the Nurse. It was designated last year as the Year of the Nurse. Due to the pandemic, they extended it into the year 2021. And today is officially the birthday of Florence Nightingale. So most appropriate that we're talking about nursing excellence when it's the birthday of the mother of the current nursing profession. So magnet designation recognizes nursing excellence and organizational collaboration. As Stephanie said, None of this happens in a silo. It takes a village. It takes collaboration. You can see for the Year of the Nurse, their tagline is Excel, Lead, and Innovate. And these are themes that exist throughout the Magnet document and what they expect to see when they come to Washington Hospital. Next slide, please. Our journey to Magnet redesignation really began long before 2011 with our original designation. You may be unaware of the study that was commissioned by the American Nurses Association to look at hospitals and find out what attributes they possess that cause them to retain and recruit high quality nurses. Based on the findings of that study, they decided to designate certain hospitals in the United States as Magnet designated hospitals and had certain criteria that they developed. The first hospital that was designated was in 1994. Long before 1994, Washington Hospital had already established some of the required elements for Magnet designation, one of those being shared governance. So we've had shared governance in the nursing division for more than 2 decades. So very visionary and innovative long before it was required for Magnet and long before Magnet was even on our radar. So we received our initial designation in 2011. Our second designation, so redesignation in 2016. And here we are in 2021 for our second redesignation virtual site visit that will occur next week, Monday through Wednesday. Go ahead, Shri. As Stephanie mentioned, and as Kimberly mentioned, Magnet is it's exclusive. Only 552 hospitals around the world, 546 in the United States, 40 in California, and 8 in the Bay Area. And at the time that we received our first designation, we were one of the very first unionized hospitals that were able to achieve Magnet designation, which really is a testament to that collaborative relationship that we have with our partners throughout the organization. Next slide. So how does Magnet status benefit the organization and patients at large? Well, first of all, it's the advancement of nursing standards and practice. There's an expectation that everything we do be evidence-based. So based on the standards in the community, what's the current literature, what do our professional associations recommend that we do, and how we take care of patients. And we modify our standards and practice on a regular basis based on the information that comes out. We have improved patient outcomes, safety, and satisfaction. Magnet is all about the so what. So you can put all your interventions in place, you can collect all kinds of data, but if you don't show that it made a difference, then it didn't mean anything. It's a cultivation of interprofessional collaboration. So even within our shared governance, we extend outside of the division to include all nurses throughout the organization, as well as incorporating our partners from infection prevention, case management, and from rehab and pharmacy and ad hoc as needed, depending on what it is that we're working on. It allows us to recruit and retain top nurses and other healthcare professionals. It's not uncommon when you interview people for a new position at Washington Hospital that one of their reasons for coming here is because we're a Magnet hospital. It's not uncommon for me to hear from some of our hospitalists and newer ER providers that nursing here is different, that there's a higher caliber of nurses that work at Washington Hospital, and it makes their job easier and they're confident in the care that their patients receive. And then it helps to expand the reputation and financial success of the hospital. People that work here recommend the hospital. And so then we have more people that come to the organization. Next slide, please. It's important to know that over the years, Magnet designation has become very rigorous and the expectations have changed. With each new document that we've produced, there's a higher standard that we have to achieve. So the very first designation was more about telling our stories. There was an increased emphasis on outcomes in the second document, and in the third document, very focused on outcomes and data. And this year they added a deal breaker. So For each designation, we've had to assess nurse satisfaction. This time around, if your nurse satisfaction scores didn't outperform in the majority of the units, the majority of the time, you were not eligible for a site visit. So it was an automatic fail. So I'm proud to say that we did exceed the standard and met all the outcomes required for nursing satisfaction. So that allows us to proceed with the rest of the document. New this year was inclusion of ambulatory areas where registered nurses work. Now, they reclassified places like the emergency department, cath lab, and OR as outpatient for this document. Last time around, they were included in the overall document. So some of the areas were previously included, but we've had to include diabetes, the rehab center, women's health. So there's a whole separate section for ambulatory care, and we have to meet standards in both categories, inpatient and ambulatory. Also new to this document is the development of transition into practice programs for nurses in all settings. So some people might think of this as being orientation, but this is really orientation on steroids. So there's a number of requirements in terms of knowledge, skills, and attitudes, the enculturation of the new hire, whether it's a new grad, whether it's somebody in a training program, whether it's a new nurse leader, how are they enculturated into the organization, and how do you measure success, and what goals do you have for them? So this is a program that we'll be submitting for accreditation in the next year before the next magnet designation. Focus on outperformance of nurse sensitive indicators and patient experience. This was a requirement in the last document and continues to be a requirement. Obtaining and celebrating new knowledge. So research was important in the last designation document, but this time we're required to have 2 completed studies and 1 in process. And we currently have 3 completed studies and several more in progress. We have a highly educated workforce. We have nurses at the bedside that are going back for doctoral degrees that are bringing research studies forward. We recently just presented a new study to IRB about human trafficking in the emergency department. So we're very active in the research realm. And the additional requirement there is that we disseminate the knowledge, that whatever we learn from doing research and quality improvement work, that we disseminate it within the organization, and that we find opportunities to share it with other professionals in the community. And then the review of the documents and the interviews will be more rigorous and if not more challenging. This visit is totally virtual. So we've worked very hard with our IT partners to make sure that we're prepared for on-unit visits that are virtual. The meetings with the VPs and executive leaders and the board will be virtual, with the community will be virtual. Fortunately, we're all a little bit more Zoom competent than we were this time last year, and it should go well. Next slide, please. The magnet document that I'm talking about reflects the magnet model. And on the side of the slide, you'll see the different components of the magnet model. So it's divided into structural empowerment, transformational leadership, new knowledge, innovations, and improvements, and exemplary professional practice. And throughout each one of those components are empirical outcomes. And that's really the so what of the document. So what, you have a new grad program, can you retain them? What's the percentage of retaining those new grads? So what that you have shared governance? What did they achieve lately? What initiatives have they put in place? So the empirical outcomes measure the impact of those other 4 elements and provide the evidence and examples throughout the document. Next slide, please. So one of the components is exemplary professional practice. And this is really the accountability and competence in professional practice systems and procedures. And magnet recognized organizations are required to have a professional practice model. It needs to align with the hospital mission and needs to reflect nurse-led research studies. It's really important to know that the model that you see on the screen was developed by the nurses at Washington Hospital. We went through a process before the last redesignation, where nurses throughout the building were surveyed for what they thought the components of the model should be. And then we built the puzzle together. It was revised to be patient and family. It originally had patient at the center, like our patient first ethic, but we all know that you can't have a patient without a family. And then we added advocacy, because that's what we do, right? We're advocates at the bedside for the patients and the family. We're that linking piece between our interdisciplinary partners and the physicians that help them to know what's going on with our patients, what their needs are, and help them to be met. On the other side of the slide, you can see some of the examples of the exemplary professional practice throughout the organization. SEN implemented a parent communication board, efforts led by Mary on the clinical operation committee for readmission, decreased the CHF readmissions rate. The interprofessional team at the infusion center was able to decrease wait times. We implemented AirPal when we moved into the new building. It's a device that facilitates transferring patients from one flat surface to another, and that decreased injuries for staff. And we've implemented a lot of best practices in EPIC. Next slide. Transformational leadership. So transformational leadership is all about the leadership and the opportunities that nurse leaders provide for those that report to them. It's the presence of really strong nursing leaders at all organizational levels who advocate and support patients and staff. And if you know Stephanie Williams, you can't have a discussion about a change at Washington Hospital without asking, how do the nurses feel about that? And has it been to shared governance? So their expectation is that you have a knowledgeable and well-educated and transformational CNO, that we've developed strategic plans that lead nursing services, and that nursing leaders are present at all organizational levels who advocate and support patients and staff members. And I'll tell you, when you're writing the document, it's a requirement in many of the stories that the nurse who led a change be part of an organizational wide committee that made that change, and that we have to be able to speak to what their role was on that committee in terms of how the change was implemented. So for Washington Hospital, there's a lot of examples of transformational leadership. The COVID response has been key. We implemented some new work in the emergency department to improve asthma care. We've decreased central line infections. We implemented Code BERT. For those of you who aren't on the call, it's a behavioral emergency response team that responds in a caring and collaborative manner to resolve behavioral issues, no matter where they occur throughout the organization. We've got a nurse mentorship program, and we've had the opportunity to improve patient experience in the cath lab. Next slide. So structural empowerment. Structural empowerment is about decentralized decision-making, also known as shared governance, and professional development. So several slides after this will show you the professional development piece. But that structural empowerment and processes that are in place, that's what I talked about existing before we embarked on our first magnet journey. Shared governance, we have multiple councils. They include clinical, administrative, technology, professional engagement, a coordinating council, an education council, and an administrative council. And referrals are brought there from the staff nurse level at the front line, as well as from other groups in the organization when they notice that there's a change that needs to be made or a problem that needs to be solved. It'll go to the appropriate council for analysis, problem solving, potential solutions, and then how will we operationalize that and roll it out at the bedside. They establish the standards for practice based on evidence-based practice. Some examples, oh, excuse me, my computer logged out. Sorry for that little break in the action. We've worked on sepsis together. We implemented a new device for measuring blood loss in the OB center. We reduced the length of stay in the oncology unit after looking at falls. We've implemented transition to practice programs, and we've done a lot of work with delivering culturally sensitive care for the homeless population. Next slide. So when I talked about this particular element focusing on nursing education, the Institute of Medicine established a goal that we have a highly educated workforce. And I have to tell you, the entire time that I've been a nurse, there was talk about converting everybody to BSN for entry into nursing. Now, magnet organizations have a high percentage of BSN nurses and advanced degrees and professional certifications. The goal was to be 80% BSN by 2019. We're overachievers here at Washington Hospital. We met that goal in 2019. Well, we were supposed to be 80% by 2020. We met the goal in 2019, and we were 85% in the year 2020. So we only hire BSN nurses, and so that makes a real difference. And we have a lot of nurses that have gone back to school for BSNs, master's degrees, and for doctorals. So like I said, we have a highly educated workforce at the bedside. Our other goal was to increase the professional certification of our nurses. And professional certification is a way of demonstrating content competence, that we have a baseline of knowledge that we all share between each other. So for example, in the emergency department, we have certified emergency nurses. In oncology, we have oncology certified nurses. There's a med-surg certification. So different specialties have different certifications. There's even certifications for nurse leaders and nurse managers. So our goal was to have 22% of nurses with professional certifications by 2019. You can see we exceeded that goal as well. We were 25% in 2019 and 32% in 2020. Next slide, please. As we talked about before, nurse satisfaction was a deal breaker. It's pivotal to magnet redesignation. It really is a reflection of how the nurses at the front lines feel about working here at Washington Hospital, and it reflects how well engaged they are. We're really proud to be able to say that we outperformed the majority of the time and the majority of the units in categories related to autonomy over their practice, leadership access and responsiveness, adequacy of resources and staffing, and interprofessional relationships. And I think it's really important to share that when we practiced for the virtual survey with our magnet consultants, they said that universally across the board, that the nurses talked about the presence of leadership in the past year and really remarked on the frequency and round-the-clock rounding of Stephanie, the CNO, and Kimberly together in tandem, and that really made a difference in terms of how they felt safe and cared for at Washington Hospital during the pandemic. Next slide, please. Nurse-sensitive clinical indicators. So clinical indicators are not a foreign subject to the folks on the board, right? We're looking at data all the time, but it's really about the so what. So you're looking at data, but are you making a difference, and what direction is it going in? So the requirement is that we have to outperform here as well in the majority of the units in the majority of the time. And we were able to do that with falls with injury, hospital-acquired pressure injuries, central line infections, and catheter-associated urinary tract infections. Next slide, please. Now, that was for the inpatient setting. We also have to look at it in the ambulatory setting. This is a newer requirement for the magnet designation. Probably not as rigorous in terms of how many indicators we had to look at, but we outperform with falls with injury. It is difficult to find an indicator that crosses all ambulatory areas. And then we were able to select a second one. The left without being seen metric for the emergency department was selected, and we outperformed in that one as well. Next slide, please. Patient satisfaction is important to Magnet, and it's important to the organization. And we outperformed in the inpatient units in care coordination, safety, patient education, and pain. And the ambulatory areas outperformed in patient education. We all know that this past year has been a little bit of a struggle when it comes to meeting the needs of patients and their perception of what's going on. And there's a lot of work happening to make sure that we connect well with our patients, that we're using iPads to talk to families, that they're well informed about their discharge instructions and prepared to take care of themselves when they get home. Next slide, please. New knowledge, innovations, and improvement. So this is a big chapter that we write about, and it has to do with access to evidence-based practice, that we support research and incorporate it into clinical and operational processes. We do have access to evidence-based practice and research. We have several subject matter experts. The clinical nurse specialists are very skilled in research, developing research studies. They mentor and coach the nurses that are interested in doing research. We have to apply those results for best practices and then disseminate them, as we talked about earlier. So some of the things that we've done here is measure the effect of reporting and referring domestic violence patients using some new technology that was more real time so that they could get immediate assistance. The factors that are involved in whether or not nurses become certified professionally. We implemented a study that's still in progress for implementing early mobility and implementing electronic status boards in the surgery waiting area. Next slide, please. So as you can see, our magnet journey, it's fun. It's a lot of work. It's made a big difference at Washington Orange Hospital. It's really been the key to success, I think, for a lot of the things that we've done, because we have the structures and processes in place really to do anything in terms of Washington Hospital. There's nothing Washington Hospital can't do if we decide to do it. Our dates for the virtual magnet site visit are the 17th to the 19th. Their goal will be to verify what we put in our document, to give us an opportunity to amplify it and brag about it, and clarify about anything that they have questions about. In terms of their strategy, they will interview people at all levels. So from the executive and board level to nurse leaders to our department partners, all the ancillary areas, everybody that it takes, that they'll be interested in what our perceptions are of nursing and how we work together to achieve the outcomes reflected in the document. I can take some questions. Otherwise, I thank you for your time and attention and really look forward to the visit next week and sharing the outcomes with you.
Great. Thank you very much, Brenda. It's amazing. I didn't realize it was 12 years that we've had the magnet designation, and it clearly has been critical to the success of Washington Hospital in improving the patient care at the bedside. You know, I think the real so what of the magnet status is the way it improves the care at the bedside, the training, the understanding, the improvement. And so I really hats off to you and Alita, and especially to Stephanie and the entire nursing staff for bringing this about and making this happen. You know, I don't think we could have gotten through last year as well as we did and taken as good a care of our patients, including the COVID patients that we had, without the hard work, dedication that resulted from obtaining and maintaining the magnet designation. So it's, you know, it's a critical success factor for our institution. And so I wish all of you and the rest of your team great luck next week. I'm sure we'll have a good outcome.
Thank you, Dr. Nicholson.
Thank you. Any comments from our other board members? Jacob, Jeannie, Mike, Bernie? No, it's all smiles, it looks like.
That works for me.
That's a good sign.
Uh-huh.
That's a good sign.
Thank you, Dr. Nicholson. Thank you, everyone.
Okay, and best of luck next week.
Thank you very much. Bye-bye.
Great. Okay, let's see. Is Dr. Killaroo with us here? He's muted still. Not anymore. Okay. Prasad, we've got the medical staff report.
Thank you. So I'm happy to say we have 583 medical staff members at Washington Hospital, out of which 351 are active. As I mentioned, we kind of hover close to that 600. I think we touched it once. Usually July, August is when the new residents are done and we start seeing a little increase in the numbers. We are still looking to have a annual or biannual dinner dance that we have for the medical staff leadership transition. Next month will be my last month as chief of staff. I have to thank all of the support I've gotten from the board during my 2 years here, and Dr. Heider will be taking over. And typically during the dinner dance, we announce the Physician of the Year, the Remo Sorority Physician of the Year Award. So I'm very happy and proud to say that this time we'll be awarding it to Dr. Mehigan. As you all know, he's been here for a very long time, has been a mentor for most of the surgeons that have been working here. So we're looking forward to honor him. We're still trying to figure out a date and time and place as far as where we're going to do that. But as soon as we have that, obviously we will let all of you know as well. And that is my report.
Great. Thank you very much, Prasad. You know, that's a wonderful choice. I think Dr. Mehigan has contributed so much to this institution. He was there when I arrived, and I've learned so much from him. He's taught everybody quite a lot and contributed so much to the institution and taking care of a very challenging patient population. So
Absolutely.
It's a wonderful thing. So I've got to get, now we're going to have the dinner dance for real?
We're still, so we had sent a survey out. Normally it's done in May, but with COVID, with all the restrictions, with everything, the consensus was we were going to look at probably June, most likely July. And then we're looking at what venues are available. So we're still in the process of trying to figure that out. But as you know, we put on a really nice show for the award winners with the little montage and everything. Then that takes a few months to get all together. So we wanted to at least get that process started.
Well, that's great. So
we'll
we'll get
when we know where we're going.
We'll get the dance floor all waxed up. I know Bernie will have his dancing shoes shined. And so we all look forward to that dinner dance. So thank you again.
Thank you.
All right, so let's move on to our Service League report. Debbie, and yeah, take yourself off mute there. There we go.
I'm off mute. It's just want to go step right in that the hours worked in the past month, and the members were about 44 members, Service League members, approximately 730 hours in the COVID vaccine clinic. The pharmacy labeling, that pharmacy with labeling actually jumped up quite a bit from about 8,000 to almost 16,000 labeling for the vaccine, which was yay, people are getting vaccinated. Making the kits for the laboratory for the pre-op testing and helping filing in the HR, and also in the COVID vaccine clinic, they've been helping there also. We have the volunteers gradually returning. Actually, they're going to be returning next month in the NUA in telemetry, and really looking forward to that. That's actually where I have my experience from, is there. So I'm actually one of the trainers for the NUA. Then we'll slowly start opening up other departments, the ED and oncology and other areas, which would be really nice. So you'd be able to see all of us back in the hospital slowly, but getting there. So very excited for that. We check on, we just do checking on the patients on their call lights, making sure if they need anything. Before we give them anything, we always check with the nursing staff or the CNAs. And that's my report.
Well, thank you, Debbie. It's such a gift that the Service League brings to the hospital and especially to the patients and families. I know they'll be very glad to have the volunteers back on the floors and helping in all the different ways, and all the cuddlers cuddling
Yeah,
the babies. I know that will come soon enough. So
Yeah.
we're really glad for that.
yeah, we're all looking forward to it, and we're very excited that we're so welcomed. So we really thank the nursing staff and all the staff at the hospital. We're very excited coming back.
Well, thank you again.
Thank you.
Okay, we'll now move on to our quality report. Mary Bowron, I think, is going to talk about our quality dashboard for the most recent quarter.
Yes, thank you. Okay, so I'm going to be presenting the quality dashboard for quarter ending March 2021. So this will include January, February, and March quality data. Starting off with our infection prevention indicators. We have our first one, which is MRSA, which is a very difficult superbug to treat. This is measured with if patients have this bug identified in their blood within 3 days of being admitted to the hospital. And we've really had continued success with this. Again, 0 infections with MRSA, I'm happy to report. And then moving on to VRE. Next slide, thanks. With VRE also is a very difficult superbug to treat. It's a type of superbug that's resistant to vancomycin, which is a very strong antibiotic, but this has managed to not respond to vancomycin. So we watch this very closely also, and we have continued to not have any patients have a hospital-associated VRE for the second quarter in a row. So this is below the benchmark from the NHSN. Next slide. Our central line associated bloodstream infections, otherwise known as CLABSI, for this quarter was what was expected on the national level benchmark, which ended up being 2 CLABSI infections. This puts us right at the benchmark. However, for us, it's obviously considered too many. We do take each case of a hospital-associated infection that's related to a device and look at it for a root cause. Both of these infections have been looked at from our medical staff leadership side and on the nursing side with infection prevention. And we've basically looked back at determining what ways we can what things we can put into place to make sure that we are maintaining the lines and the dressings after they've been placed. And we're doing daily checks with the nursing leadership, and charge nurses on rounds are working closer with infection control to make sure that these lines are maintained well. And we'll continue to do that. And we are hoping to get back down to 0 where we were the quarter before. Next slide. For right now, the biggest challenge we're having in infection prevention related to hospital-associated infections is definitely our catheter-associated urinary tract infections, otherwise known as CAUTI. This quarter, we had 8. The national benchmark expects closer to 2 for a hospital of our size and type. So we recognize that after now being at the 4th quarter above the benchmark, we had to really, take a time out and immediately put interventions in place to be looking at this on a daily basis. So we've established a CAUTI prevention task force. This task force is multidisciplinary. It's made up of 3 medical staff members, members from infection control, nursing leadership, frontline nurses, frontline physicians. We meet weekly in the CAUTI prevention task force and look at these cases specifically these 8 cases we looked at very closely, and we basically determined that one of the areas we think we can make improvement is reducing the number of line days that patients have catheters in while they're in the hospital. As you know, most of these catheters are only in place when they absolutely have to be for medical necessity. And in doing our root cause analysis, we found that we have some room for improvement in that area. And we have some room for improvement in establishing a nursing-driven protocol that will allow for nurses to follow certain criteria and take out the catheter the moment it no longer meets medical necessity. So when you have a protocol like that in place, it gives the nursing the ability to reduce the line days by taking out the catheter as soon as possible, so you're not waiting for any extra delays and trying to get an order. So that's one of the first things that we're working on, so that we can make sure that patients don't have a catheter unless they absolutely need it, because if you don't have a catheter, then obviously you don't have a risk for developing an infection related to that catheter. The other thing that we are doing is looking at how we take care of the catheters while they are in place, if they meet medical necessity. And so infection control is working very closely with nursing. We're talking to the CNAs on the front line who take care of these patients who have catheters, seeing what we can do to help them and on understanding, how to do the care. Are there better products to use to do the care of the line, etc. So again, we're taking this very seriously. We recognize it's a significant issue, and again, meeting weekly. We've had a lot of support on getting resources from this on an executive staff level, and our CNO, Stephanie Williams, is also meeting with us weekly and makes it a priority and is helping guide us towards a solution. So I will actually be bringing this back the next quarter. I report this out, and we'll bring in further details on where the county task force is, and hopefully see a reduction in the events. For C. diff, this is another area where the infection prevention program was working with a multidisciplinary team over the last year and a half to implement change after we had some issues about mid-2020 with C. diff. And we are happy to report that for the third quarter in a row now, we are below the benchmark. We did have 3 C. diff infections this quarter. For a hospital of our size and type, the national benchmark from CDC expected us to have closer to 10. So we are very far under the benchmark. I think that this is a result of a similar process that I mentioned with county. It's really important that all of the disciplines come together and work and take a bundled approach on reducing the risk for this hospital-associated infection. And that's what we did with C. diff. It's the same thing. We have medical staff leadership active, working on helping us reduce C. diff. Nursing is also active. We've worked very closely with the lab on specimen testing, collecting of the specimen, etc. And we are continuing to meet with that group and discuss each identified C. diff and look for root cause analysis. So we're in the sustaining phase of this. We do not want to pull back, of course, on any of the approach we're taking, because we have found that it's working well. One of the areas that we think has really helped is we have a clinical decision tree that the team uses, the whole care team for the patient, to identify which patients should be put in isolation, how they should be tested, antimicrobial stewardship related to these patients, and which means basically monitoring very closely, how we prescribe antibiotics on a whole in the hospital reduces your C. diff infection. So we're sustaining, and we'll continue with that. Surgical site infections are a risk factor for anybody having a surgical procedure, but especially for surgical procedures that relate to the colon. And the CDC monitors these very closely for all hospitals. And we did not have any colon infections this last quarter related to patients who had had a surgical procedure. And again, as you can see, we've only actually had one for more than the last year and a half. And our next surgical site infection that we monitor closely is abdominal hysterectomies, another one for risk for developing an infection after procedure. And again, we're at our 5th quarter with 0 surgical site infections related to hysterectomies. Hand hygiene is something that the Patient Safety Committee is working on. It will be one of their top priorities for our fiscal year 2022. It's always been a priority for us here at the hospital. It's something that is a challenge, and we're always going to have an initiative related to hand hygiene because we have to continue to do the monitoring and take lessons from what we've learned by watching the front line when they fail to comply with hand hygiene. In this particular quarter, we were 3% lower than the goal, which is from Joint Commission, which is 90%, and we were at 87%. We obviously are ultimately want to be at 100%, but what we try to do is when the infection control team is rounding and identifies non-compliance with hand hygiene, the standard is to really find out why. So did the healthcare worker have the right access to hand hygiene materials such as your Purell? Were they interrupted in the middle of their care after they're done before they went to go wash their hands? All these sort of things we're trying to learn from, and the Patient Safety Committee is taking that data and looking at it closely. The other thing is that the way we monitor our hand hygiene has multiple elements to it. It's just not a matter of watching, people to see if they wash their hand in one part of their interaction with the patient. There are multiple times that we monitor during an interaction where we expect to see hand hygiene. So an encounter can have multiple levels in it. And so we're learning lessons by watching areas that fall out with that and hoping to, of course, get beyond the 90%, closer to 100%. Moving into our nursing sensitive indicators, I think that we've heard a great summary of how well our nursing team does here and what great quality they offer our patients. And the next 2 indicators that I'll be going over really are a reflection of that for this quarter also. We use the National Database for Nursing Quality Indicators as our benchmark. One of the things that's monitored very closely is patients who fall and sustain an injury related to that. We did have some problems with that in towards the end of 9/20, and the team really came together and has put in interventions that we've been able to sustain 2 quarters below the benchmark now. And again, for this quarter, it's the same thing. This is actually just a reflection of 1 fall. What I actually really like about this nursing indicator is there is very low tolerance for any patient falling and sustaining an injury. Even 1 or more can put you close to the benchmark. So we take each one of those very seriously. There is a huddle done after the fall to identify what fell out and what we can put in place in the future to prevent this. But we've overall been doing really well with it. Hospital-acquired pressure ulcers are another nursing sensitive indicator that we watch very closely because it's a reflection of taking care of the patients that don't have as much mobility as they did prior to their hospitalization and require a lot of timely care from nursing on rotation and making sure that the patients are in a proper bed that supports their skin and doesn't harm it. And we also look at, of course, multiple other things around nutrition. But for this quarter, it's a great reflection of that care that we feel very comfortable in quality is happening on a regular basis. And we've had 0 ulcers in a category 2+ in this last quarter. So again, this falls right in line with what we heard earlier from our magnet team. Readmissions are another area that we continue to have challenges with in the hospital. We do have a dedicated team that's looking at readmissions. And as I go through each disease state, I'll be sharing with you our plan that we're using. We have to approach each disease state with a unique set of interventions that will help us reduce patients' risk for coming back to the hospital. And starting off with our AMI, this quarter, we've done well. The 2nd quarter in a row, we are below the benchmark, which is 16%. We did have 1 patient come back out of 21, but that put us at 4.8. So AMI is something that has been less of an issue for us recently. But moving into the next slide, for pneumonia, pneumonia and COPD continue to be our biggest challenges in readmissions. But just to start off with pneumonia, our rate was 24.6 this quarter. The national benchmark is 16.6. So 15 of 61 patients returned. The patient population that we're monitoring closely right now that we determined to have been the highest risk for us are patients who are 75 and older. And in these 15, we have continued to identify that we are actually narrowing down on the highest risk population. Out of the 15, 13 were actually over 80 and 2 were over 75. The average length of stay for these 15 patients on their initial index admission was 8 days. Very sick patients. Only 3 of these patients went home from discharge. The other 12 either went on to a skilled nursing facility or went home with home health. So that for the committee was a little bit of a something that made us stop and think. So if the patient went to a SNF and went to home health, they actually had further monitoring after discharge. So your first guess would be that that patient is less likely to come back because they had good transitional care planning, but they're also very sick patients. So what we've decided to do is meet with the skilled nursing facilities and home health teams weekly, and we're going to be getting reports back on the patients while they're in their care, and especially working closely with them to identify their particular readmissions. And we've identified high quality networks for SNFs and home health that are especially working with us to look at this patient population and see what improvements we can make moving forward. For the next slide, heart failure is a very similar process we're doing. We had 12 patients come back out of 52. That put us at a readmission rate of 23%. The national benchmark is closer to 22%. The same exact approach will be taken with heart failure patients because they're also in the same risk factor. These patients stayed for less, about 5 days, but they were also elderly. Excuse me. 10 out of the 12 patients were actually over 80. Excuse me. Moving on to the next slide. COPD, as I mentioned before, is another area that we're challenged with. We did have 4 patients come back out of the 17, putting us at about 24%, which is above the national benchmark, 19.6, which is basically 20%. These patients are, as you know, chronically ill. The focus area with this group is making sure that patients in this category can get to pulmonary rehab when they qualify for it and meet criteria. Our respiratory team is looking at this very closely for us. They're also active members on our readmissions reduction committee. And that is the transitional care area that we're focusing on. And also making sure that these patients go home with home health and have the support with making sure that they have their oxygen in place. And caregiver support is another thing we're looking for in this group because they've also been identified as on our phone calls as not having a lot of transport to get to their follow-up visits, et cetera. So those will be our focus areas for COPD. A successful area in readmissions relates to our patients that have coronary artery bypass grafts, otherwise known as CABG. We are at our 3rd quarter in a row where we have not had any readmissions in this high-risk readmission population. And this has been a great reflection of the care team there and the transitional care planning. I think we're doing well with that particular procedure group. And the same applies to our elective primary hips and knees that are replaced here at Washington Hospital. We've always sustained far below the national benchmark, which is about 4% of these patients would be expected to return on readmissions. And we're at 0% in this last quarter. So out of the 11 patients who had this procedure, 0 returned to the hospital within 30 days. And that concludes all of my quality indicators for this quarter. Any questions?
Great. Thank you very much, Mary. Any questions from the board? No, I'd have to say you have some really nice looking statistics on many matters. We've got some ongoing challenges in other areas, the county. But to see the great progress that you've made on C. diff over the years is wonderful, a showing of what the quality team can do in working on these very difficult problems. So keep at it, and we expect ongoing good results. Thank you so much.
I had a question. I had a question. Do you think the county numbers had anything to do with the COVID patients?
So we have had that discussion, and the first background I'll give you to that is that the benchmark that is established for county is actually based on historical national hospital data from 3 years ago. So prior to a pandemic, obviously. And so that's probably one of the criticisms about a county benchmark right now. First of all, is that it's not reflective of a population that we've been dealing with in the pandemic. But in this particular group with the 8, I think only 2 had COVID because it's sort of when the COVID census started to drop off. They were identified in January. So the only thing is that the benchmark is stricter than maybe should be anticipated for this group. We do look at if they have COVID though, because like you said, it's always a consideration right now with data in general. Sicker patients.
Thanks, Mary.
Great. Any other questions, Jeannie, Bernie, Jacob?
Thank you.
Okay, thank you very much, Mary. Okay, we'll now move on to our finance report. Chris Henry.
Okay, thank you, Dr. Nicholson. Tonight we'll be looking at the operating and financial results for Washington Hospital for March. And we'll jump right into our acute inpatient statistics. Average daily census for the month was 12.5 below budget at 138.9. Admissions were 14% below budget at 793. And our patient days were 8% below budget at 4,305. Of course, those two percentages being out of whack indicates a longer average length of stay, as we've been seeing most of the year. Average length of stay for the month was 12.4% higher than budget at 5.7 days. Outpatient observation equivalent days for the month were 59, higher than expected in the budget at 245. Moving into utilization, the case mix index for the month, which is the indicator of the severity of the patients we saw during the period, again remained high at 1.662. We had budgeted for a CMI for March at 1.528. Deliveries were 27 below budget at 102. Surgical cases were pretty close to budget, just 3 off at 392. And our cath lab procedures came in strong, 169 higher than budget at 528 procedures. Outpatient visits came back strong in March. They were 723 higher than budget at 8,005. So it's nice to see that outpatient activity really ramping up strong again. Emergency visits continued to remain lower than expectations. About 984 lower than budget at 3,418. And of course, we did close our RSTU a number of months ago. Moving into utilization again, getting into the details of cath lab and surgical. In the surgery department, joint replacement cases were pretty close to budget, as well as general surgical cases, both just 1 higher than budget. Neurosurgical cases and cardiac cases for the month came in a little lower than expected, with 18 neurosurgical cases for the month and 14 cardiac surgical cases for the month, but still running a lot higher and recovering from where we were at the same period last year. In the cath lab, really higher activity across the board. with peripheral vascular really leading the way at 286 cases. That's 131 higher than budget. So our surgeons that are working in the cath lab really are ramping up and getting busy. Nice to note also to see neurointerventional radiology coming back, 3 above budget there, and that's a really good indicator. Those numbers have been higher for the last several months, so starting to see that business come back. Moving into productivity, our productive FTEs for the month were 6.5 below budget at 1,306. We had 133.6 non-productive FTEs for the month, giving us total FTEs 4.6 lower than budget at 1,400, almost 1,440, just a little bit under that. However, our FTEs per AOB came in 0.26 higher than we expected at the budget at 6.47. So we did have a little trouble flexing down in March to the activity, but we're, again, in March, we're really coming off a really hectic January and February. So COVID was starting to tail off in the month, and I think we were a little hesitant to get too aggressive flexing down. Moving into the financials, total patient revenue for the month came in a little over $1.7 million higher than budget at $183,717,000. Our deductions from revenue for our contractuals came in at 77.64%, a little bit lower than the expectation of 77.84%. We'll get into the details there. Our contractual allowances for insured patients came in a little bit higher than budget, about 2.2% higher than budget at $140,966,000. We did have a higher percentage of government-sponsored patients in the month. We're seeing Medi-Cal start to ramp up, and I think you'll hear a little bit more about that in Kimberly's report. But that was offset by our provision for bad debt and charity that came in about $2 million lower than budget. So again, in total, our contractuals came in about just a little bit less than $1 million above expectations at $142,645,000. So we ended the month with net operating revenue about $676,000 higher than budget at $41,345,000. Operating expenses for the month came in $306,000 higher than budget at $40,417,000. A lot going on in there, a lot of stuff offsetting. Our salaries and wages, although our FTEs were lower, our salaries and wages were actually about $344,000 higher than budget. A lot of that driven, I think, by a higher average hourly rate, in relation to the mix of professionals that we had working at the hospital coming off of COVID, and also a little bit of overtime still being utilized. Benefits for the month came in $427,000 lower than budget. A large part of that came from pension, which came in $400,000 less than budget, and workers' comp claims, which came in $19,000 lower than budget. Also, our pro fees and purchase services were lower than budget by about $176,000, largely driven by purchase service mostly, and that was driven by a combined variance in valet, security, community relations, and collections. We're just not using those services as much during the shutdown. So those combined for a big savings in the month. So we ended up March with a positive bottom line of $928,000 against a budgeted loss of $54,000. Non-operating income for the month came in $141,000 lower than budget at a $497,000 loss. We did have an unrealized loss in our investments for the month at $465,000. And then we had some offsetting variances. Interest expense came in lower than budget, about $457,000 as a result of some of the refinancing activity we've done. bringing those numbers down. And then our rental income came in about $206,000 lower than budget at $80,000. We have lost a number of tenants during the COVID crisis, unfortunately for our tenants and for us. And we are trying to work with the remaining tenants to keep them in the building. I will say that activity is really starting to pick up. We've had a number of inquiries and we're seeing a lot of touring activities, and we are currently in negotiations with 2 tenants looking at really large spaces. So things are starting to hopefully turn around at Fremont Office Center. So we end the month, and again, this is the Governmental Accounting Standards Board presentation, which is the presentation we're required to use by governmental rules. We end up with a net income for the month of a positive $431,000 against a budgeted loss of $410,000. So a good month for us given what we've seen the last 12 months or so. So moving into our Financial Accounting Standards Board presentation, and just for folks that aren't familiar with all this accounting stuff, you know, governmental rules tend to be different from everybody else's in a number of areas, and that's true in accounting. So this is a representation of how an analyst might adjust our Governmental Accounting Standards Board presentation into something that's more comparable to the non-governmental entities. So the first thing we do is we reclassify $615,000 of revenue bond interest expense out of the non-operating category and up into operating expenses. That changes our operating income from a FASB perspective to $313,000 against a budgeted loss of $1,241,000. We then exclude down in the non-operating section our GO interest expense and the related property tax revenue that supports the debt service on those GO bonds, and we remove our unrealized loss on investments to end up with non-operating income, again from a FASB perspective, of $427,000 and a total bottom line of $740,000 against a budgeted loss of $677,000. Quickly moving into our earnings before interest, taxes, depreciation, and amortization. And again, this is another way of looking at our numbers to figure out how much income we're generating for our debt service and for other expenditures in the organization. And we first pull out our depreciation expense from our operating expenses to come up with EBITDA of a little over $4.8 million against a budget of $4 million. We then move down to the non-operating section and we carve out that interest expense, and we end up with non-operating income of $1.4 million. So combined in the month of March, Washington Hospital's operating and non-operating activities generated about $6.3 million of income to provide for the debt service on our bonds and other capital spending and other activities. So are there any questions on March?
Yeah, Chris, I had a question on the provision for bad debt. What caused that to go down?
Yeah, we're seeing just a lower level of private pay in our gross revenue. I think for the month it was below 1%, and we generally expect about 2% of gross revenue coming from unsponsored patients, and that's really driving those numbers down. It's been that way all year. I don't have an explanation for why it's down other than, you know, the same kind of reasons that people may not be showing up to the ED. But it's really actually benefited us a lot this year.
Good. And our length of stay in March was 5.7, a little higher than budgeted. Were we still seeing a significant number of COVID? Was that affected by COVID? Because I thought our COVID census was substantially less in March.
Yeah, it was coming down. That number is generated off of discharges. So we had a number of discharges in March that had really long lengths of stay.
Okay.
I think, you know, we should start see those numbers coming down, but even in March, we still had some really long lengths of stay still in-house. So hopefully those numbers start coming down.
Okay, so that was the tail end of the COVID surge of January and February.
Yeah, I think I went back and looked. We were still running in the high teens in March for our average census on COVID. So, you know, still not to where we are now, but not where we were in February, that's for sure.
Yeah, now we're well less than 10 usually.
Yeah.
Yeah, good. Okay, any other questions for Chris from the board members? Okay, if not, let's move on to our operations report. Kimberly, if you're ready.
Yes, all right. I will give the operations report for April. Gross revenue of $183.8 million for April was above budget by $11.9 million or 6.9% and above April of 2020 by $79.1 million or 75.5%. Inpatient gross revenue of $109.9 million was above budget by $1.1 million and $31.8 million above April of 2020. And outpatient gross revenue of $73.9 million was above budget by $10.8 million and $47.3 million above April of 2020. And I just want to remind everyone, April of 2020 was the first full month when we had the shelter in place. So that was a time when our census dropped significantly. So you'll see large variances between comparisons with April of 2020. And so Chris and his team has also went back and looked at the prior 8-month average to give us sort of where things were pre-COVID. And just to put perspective, you know, that the prior 8-month average, July 19 through February 2020, their total gross revenue was $177.4 million. So, you know, in terms of this April, with 183.8, we're doing well in terms of that. Also in April, we had 26 COVID-19 discharges, representing 3% of total discharges. Fiscal year to date, the average monthly COVID-19 discharges were 74 and represented 9% of total discharges. So again, coming down significantly in terms of the number of discharges of COVID-19 patients. Moving on to key census statistics. I know we just had a discussion about length of stay. So average length of stay this month was higher than last month at 5.92, and it was above the budget of 4.96 by 0.96 or 19.4%. Really, there are a couple of reasons in terms of this, and one, of course, the higher acuity of admitted patients. And in general, our COVID-19 patients have a higher acuity and average length of stay of 9.5 days. The average length of stay for the 26 COVID-19 discharges in the month was 8.2 days, and 2 of them stayed longer than 20 days. But really, one of the main drivers of this long length of stay was of the non-COVID-19 discharges, there were 3 patients with really long length of stay. The first was 196 days, the second was 154, and the third was 76. So if you exclude those 3 patients, our average length of stay was 5.4. So our case management team worked, and as I said, those at this point, those were the really long lengths of stay that we've had in-house. So going back to up to the statistics, outpatient observation days were 73 or 41.7% above budget at 248 days, and average daily census of 140.3 was below budget of 145.3 by 5 or 3.5%. And you can see the average daily census was 32.4 or 30% above April of 2020. Looking at our admissions, they were below budget by 108 or 12.3%. And admissions for the month were 130, 20.3% above April of 2020. If you look at the prior 8-month average, that was 956, of which 82 were inpatient joint surgeries that have shifted to the outpatient. So normalized, it's about 874, was the prior 8-month average. Moving on to patient days and looking at that trend, although admissions were 12.3% below budget, patient days of 4,208 were only below budget by 3.5%, or 152 due to the longer length of stay. And again, patient days for the month were 970 or 30% above April of 2020. Looking at our surgeries, we had a strong surgical month. We had total surgeries in April of 389, which were above budget by 6 or 1.6%. Surgeries were 251 above April of 2020, and the prior 8-month average was 382. So even a few surgeries above our prior 8-month average. Inpatient surgeries were 51 or 26.3% below budget at 143, but 47 or 49% above April of 2020. Outpatient surgeries were 57 or 30.2% above budget at 246 and 204 above April of 2020. Looking at our surgical activity broken down, you can see general surgical procedures were below budget by 1.5% at 194, but were 103 above April of 2020, and in the prior 8 months, that average was 196. Looking at joint replacement surgeries, we're below budget by 1 at 160, but we're 129 above April of 2020, and the prior 8-month average was 153. Neurosurgical procedures were also above budget by 2 at 22, and were 13 above April of 2020, and the prior 8-month average was 23. And cardiac surgical procedures were above budget by 6 at 13, and were 6 above April 2020, and also the 8-month average for the cardiac surgical procedures was 11, so above the 8-month average. So overall, a strong month for surgical services. Also, you'll see we had another strong month for cath lab procedures. Cath lab procedures for April were 481, which were 120 or 33.2% above the budget, and 282 above the April of 2020. The prior 8-month average, July 19 through February 20, was 426, so even above that. Looking at the cath lab cases for April were 209, and which was 127 above the same period of last year. So inpatient cath lab procedures were above budget by 63 or 30.6% at 269 and 116 above April of 2020. And outpatient cath lab procedures were above budget by 57 or 36.8% at 212 and above the prior year by 166 procedures. So again, a good cath lab activity, and then looking at it broken down, you can see that peripheral vascular procedures were above budget by 45 or 27.8% at 207. And looking at that prior 8-month average, which was 197, so above the prior 8-month average. Cardiac procedures were above budget by 47 or 40.5% at 163, and also above the prior 8-month average of 135. Our non-vascular interventional radiology procedures were above budget by 26.3% at 101, and the prior 8-month average was 88. Lastly, our neurointerventional radiology procedures, again, were above budget, as Chris noted last month, and they were above budget by 7 at 10, and they're also above the prior 8-month average, which was 6. Moving on to our deliveries. Our deliveries for April of 121, they were below budget by 17 at 12.3%. You may have also been reading and I know there's a number of news stories about the national trends of birth, and what we're really seeing is for 2020, it dropped 4%, which was a record low for the country, and on average, the decline had been about 2%. So this is something that's been impacting all hospitals in terms of deliveries. And deliveries were 5.5% below of April of 2020. So you can see that they were even below the April 2020. Looking at our non-ER outpatient trend, the outpatient visits were at 7,397, which were below budget by just 29 visits or 0.4%, but were above April of 2020 by 4,695. The prior 8-month average was 7,433, so still down from that 8-month average. Our X-ray visits were below budget by 138 or 7.6%, and our lab visits were above budget by 118 or 4.4%. Looking at our emergency room visit trends, you can see visits of 3,693 were below budget by 253 or 6.4%, but were above the same period last year by 1,617. If you look at the 8-month average, it was 4,454. So our emergency room visits are still about 83% below our pre-COVID level overall. Moving on to the gross revenue recap, our emergency visits were below budget by 6.4% and had a lower level of mix, so driving emergency revenue down by $1.5 million or 12.9%. Our deliveries were below budget by 12.3%, driving birthing center revenue down by $361,000 or 10.7%. Patient days were below budget by 3.5%, but patient acuity was higher, resulting in room and board revenue up by $1.1 million or 3.2%. As mentioned, our total surgeries were higher than budget by 6 or 1.6%, and there were more neuro surgeries and cardiac surgeries, driving surgical services revenue up by $3.3 million or 9.6%. Cath lab procedures were above budget by 33.2%, driving cath lab procedure revenue up by $3.7 million or 29%. Lastly, inpatient visits and outpatient activity drove ancillary services revenue above budget by $5.6 million or 7.3%. Moving on to our payer mix, you can see that it is somewhat mixed. So you can see our government-sponsored patient revenue made up 72.7% of our total gross revenue. I do want to note that our Medi-Cal sponsored patients percentage was 21.5% compared to 18.6%, so up about 3% overall. And this could be in terms of seeing also some our individuals that have lost their jobs or have gone onto Medi-Cal or seeing some of the higher unemployment. Also, HMO was 3.4% of gross revenue, which is above budget by 2.6%. Our PPO was 22.3% of gross revenue, which is below the budget of 24.2%. And lastly, our private pay was 1.6% of gross revenue, which is below the budget of 2%. Looking at our productivity indicators, our productive FTEs were above budget by 19 or 1.5% at 1,278.7. Our non-productive FTEs were above budget by 18 or 10.2% at 194.9. Our total FTEs of 1,473.6 were above budget by 37 or 2.6%. But as you can see, if you look at our productive FTEs per AOB, came in at 5.45, which were slightly lower than the budget of 5.48 or 0.5%. So overall, we did a better job of flexing in terms of to the volume. Our total FTEs per adjusted occupied bed of 6.28 were slightly higher than the budget of 6.25 by just 0.5%. So if you look at our total FTEs, if you look at it compared to the flex budget of 1,473.6 FTE, productive FTEs were below the flex budget by 18 FTEs, and non-productive FTEs were over the flex budget by 18, so right on our flex budget. Moving on to our other outpatient statistics. Our Whitney Clinic visits were below budget in April by 689 or 4%. Moving on to the DevCo visits, they were visits of 2,692 were below budget by 737 or 21.5% for the month of April. And as you can see, really, this is driven by mainly two areas. The first is the Ohlone College Student Health Center. As you know, Ohlone still has not done in-person, does not have students on campus. The Ohlone College Student Health Center is actually our staff there. They are helping out the college in many other ways and helping to get it prepared to reopen in the fall with having some students. I believe they're going to have about 50% of students on site. And they're also working with Washington Township Medical Foundation to see any patients that are needed through the foundation. So we will be seeing probably some student visits coming into the fall when students do come back to the college. The other area you can see is that their Washington Urgent Care is below budget by 650. As you know, we've reduced the hours since February, and as mentioned last month, we will be closing as of June 30th, 2021, as we are in discussions with other organizations about offering urgent care throughout the community. But Washington Outpatient Rehab Center is down 11 visits, and Washington Outpatient Surgery just down by 6, and Washington Oncology Center, our treatments are up by 29. Lastly, we're moving on to key financial statistics. Days cash on hand for April ended at 155 days, a decrease of 4 days from last month. We had a large payment of the 403B match for $2.2 million, in addition to some higher operating expenses. In May, we expect to receive $797,000 for federal supplemental program. The IGT of $384,000 for this program was paid out in April. Days of gross revenue and accounts receivable were 66, which is additional 2 days. Continue to have high volume and high dollar accounts compared to last year. And for charity care, we're at $190,171 in charity care applications that are pending or approved in April. Lastly, looking at our quarterly summary of homeless patient activity, fiscal year to date through March, there were 1,713 patient encounters representing 759 homeless patients, of which 249 had more than one encounter during the period. The estimated total unreimbursed cost for fiscal year to date through March is about $3.8 million. And that is the statistics for April. Are there any questions?
Questions from the board members?
What a difference a year makes. It should be a song.
Yes, that is true.
Yeah.
It's really good to see some return towards usual activity. And, you know, it's not really fair to be comparing to 2020. So we'll probably have to add another column for 2019 to the statistics to see where we were pre-COVID.
I know.
As we compare.
No, I agree. That's why we tried to at least do some sort of 8-month average. But yes, Chris and I will talk about that, because I agree. It's hard to sort of give a perspective of where we should be at this point.
It really brings home is how challenging and difficult things were last year when we look at some of those numbers.
Right.
That's very good. Okay. So we have two action items tonight, and I'll let Dr. Stewart introduce the first one. Item A.
Sorry, I was getting off of mute.
It's okay.
In accordance, Mr. President, in accordance with district law, policies, and procedures, I move that the board approve resolution number 1225 to authorize the chief executive officer to enter into a joint venture agreement with the University of California, San Francisco as follows. Number one, the board of directors authorize the chief executive officer to execute the LLC agreement attached hereto as Exhibit A. Number two, the board of directors authorizes the chief executive officer to execute a grant deed to transfer the district's 51% interest in the real property located at 45388 Warm Springs Boulevard to the joint venture LLC. Number three, the board of directors authorizes the transfer of funds from the district to the joint venture LLC in the amount of $2,040,000 described in the recitals as the district's contribution. Number four, the board of directors authorizes the transfer of the district's pro rata portion of any unspent funds previously contributed by the district under the tenancy and common agreement to the joint venture LLC. Number five, the foregoing resolution shall be contingent on the following. Number I, UCSF has approved the LLC agreement in substantially the same form as attached hereto as Exhibit A. UCSF has approved the transfer of UCSF's 49% interest in the real property located at 45388 Warm Springs Boulevard to the joint venture LLC. And UCSF has approved the transfer of UCSF's contribution to the joint venture LLC. Number six, the chief executive officer is hereby authorized to enter into any agreement or contract document necessary to carry out the intent of this resolution and to take any and all further actions which in the determination of the chief executive officer are necessary and proper to eventuate the intent of this resolution.
Thank you very much, Dr. Stewart. Do we have a second?
Second.
Thank you. A second from Dr. Eapen. And Kimberly, I understand you have some background information on this.
Yes, we're very excited to be presenting this very important strategic initiative for recommendation for approval to the board of directors. And Ed Fayen is going to give an overview again of what we are going to be looking at developing on the site in terms of a very comprehensive outpatient center with both primary care and specialty care along with ancillary services. So I'm going to turn it over to Ed to talk about it in a little bit more depth with the board of directors.
Thank you, Kimberly. The project or the entity that we are joint venturing with UCSF obviously is located in Warm Springs. It's a key strategic initiative focused on outpatient primary and specialty care, and obviously partnered with UCSF. So, you know, the vision here is that we provide premier healthcare services to the southern portion of the district in trying to take advantage of the strengths of both Washington Hospital and the relationship we have with UCSF. The facility is going to be an outpatient-focused facility that would provide one-stop shopping for medical needs for the residents in the South County. And it's focused towards the needs of the patient population down there and the local employers, and that area, as you're aware, has an industrial base that we also plan to provide services to. To remind you, the location of the center is sort of in the heart of the area that is being redeveloped, right across literally the street and parking lots from BART, right across the train tracks from Tesla, but more importantly, right in the middle of the development of the Toll Brothers development, Lennar development, and Valley Oak, with Sobrato also supposed to be developed sometime in the future. The first three are all under development now, and construction going on now, Sobrato to occur in the future. And you can see that our building is sort of centrally located in this development area. As you can see the development going up on the left, and you can see the Sobrato properties undeveloped on the right. The project, let me just give you a quick view. The project is to develop the existing property and make it more visible and accessible to people in the area. If you look back on the original picture, Shri, if you can circle there, that is the area that is shown in the next slide, and you can see that will be, as you drive in the driveway to the areas, that will be the focal point of the building, and clearly the entry point for anybody coming up to the building into the outpatient facility. So the service lines that are proposed to be provided here, let's talk first. We're trying to be the first to market outpatient care center in the area that we plan to develop over time in partnership and ownership with UCSF, providing primary care, but also several specialty cares, specialty lines, including pediatric specialty lines. So in the first phase, we're going to be putting in primary care, both for adults and for children or adolescents and children. And then we will have specialty care in there as well as required and as the demand is in the area. In addition, we'll have some ancillary services, including imaging and pharmacy. We would have urgent care. This again is to provide services to both the local base of residents plus employers in the area. The second phase would include ambulatory surgery, the therapies, and additional and more specialized imaging services. Our time frame is for the first phase, which is the one that is most concrete at this point, is to complete the design phase by November of this year. We have been out in an RFP process. We have gotten RFPs back. We are finalizing the analysis of that, and we'll announce the design team by the end of the week. And then we will go through a design process, ultimately achieving permitting by February of 2022, then moving directly on to construction, which will take a little bit more than a year. And then the schedule is right now that after that, we would then move on to the ambulatory surgery and other services part of the project. The joint venture, again, is with UCSF, a single-purpose joint venture, limited liability corporation, 51% owned by Washington, and the management will be led by Washington. I don't know if Paul or Nick want to add anything else about the partnership?
Not particularly.
Okay.
Thank you. But if the board has questions about it.
Okay. The construction costs, these are the projected construction costs for phase one. And that's what we're focused on right now. You can see it's split, the 5149, between Washington Hospital and UCSF. In the resolution, it addresses the top line, which is the design fees. So the first resolution addresses those, and the second resolution addresses the rest of the construction costs for the project. Phase 2 would be to follow and is comparable in cost to Phase 1, mostly because it includes the surgery center. So tonight, we'll be requesting approval from the board for the formation of the limited partnership, the ability of the CEO to sign all related documents, and approve the cost of Phase 1 construction.
Great, thank
Any
you very
questions?
much.
Okay.
Kimberly, do you have any comments?
You know, I think, as I mentioned at the very beginning, this is a very important strategic initiative for the healthcare system. And really, it demonstrates us going out into the community to provide services to our community where they need us the most. And really being able to provide a full range of services in partnership with UCSF. So being able to provide the primary and specialty care with the providers that we have locally, but then those that we may have any gaps in services to be able to have UCSF help us to assist with that. And then really, if there's any further services that are needed on a tertiary basis, be able to have easy access that way. So really looking for us at the needs of our community, and especially down in that Warm Springs area, and to develop those programs and services to meet the needs of the communities. There's a school that is going to be opening down there, but there's also a number of employers. And so really working with our employers down in that area to provide them services to help to ensure the healthy workforce and safe workforce for them too. So it's really spanning a lot of different areas that we've been focusing on, and it's part of our strategic positioning of the healthcare system.
Thank you, Kimberly. Any comments from the board members?
Timing is good and it's a wonderful opportunity.
Yeah, I agree. Mike, you've been a strong proponent of this project. Any comments you'd like to make at this point?
Well, I could just say that I think the Toll Brothers development, their first phase is sold out. And there's strong appetite for young families to purchase homes in that area. And I don't know, it's probably going to be north of 4,000 homes with plenty of children. And as Kimberly mentioned, there's a school that's already built. It's not open yet, but it's already built. So it's just, I think we're in at the right time at the beginning of the whole, as close to the beginning as we can be, reasonably can be. The acquisition of the property was just really wonderful. I mean, we rather than buying a bunch of dirt and working through the construction of that, we bought an existing building and a building that was not that very difficult to modify to our use compared to some other buildings that we might have purchased that could be quite difficult. So, I think it's an ideal time, like Jeannie said, and I think the community down there is going to really enjoy it. I know the employers are going to enjoy it.
Thank you, Mike. Jacob, Bernie?
Yeah, I mean, with such a large community, I think an extended urgent care there, I think probably would be very useful for people to, come back from work and, if the kids are sick and things like that. So I think an extended urgent care, I think, would be great.
And I think we have a great partner. I think the other thing that's really good, it's very important that you pick the right partner. And I think UCSF has tremendous capabilities to fill any kind of gaps that we might be able to provide, and not just funding gaps, but the physician gap and treatment gap. So it's just a great partner to have, and so I'm very happy with that.
I also am very excited about the project. It's stunning to drive by that area and see the size of it. When Mike mentions 4,000 homes, it's incredible to drive by there and see what's happening down there. It's wonderful that we've been able to get in there in the timing and the process that we're doing. This is very exciting.
Yeah, I agree with everything that's been said. It's the right time, the right place, and the right partner, and our community is extraordinarily blessed that we can partner with one of the top medical centers in the world to bring that level of medical care to our community. So with that, I'll call the question and ask Cheryl to do a roll call vote.
Director Nicholson,
Aye.
Director Yee,
Aye.
Director Stewart,
Aye.
Director Eapen,
Aye.
Director Wallace.
Aye.
Great, motion passes unanimously. So now we'll move on to the second part of this, which is item B, resolution 1226. Dr. Stewart.
Mr. President, in accordance with the district law, policies, and procedures, I move that the board approve resolution 1226 to approve the district's portion of the estimated phase 1 construction costs for the Warm Springs Health Center Partnership, LLC, and authorize the distribution of funds as follows. Number 1, the Board of Directors approves the phase 1 construction estimate. Number 2, the Board of Directors authorizes the Chief Executive Officer to make further disbursements of district funds to the joint venture LLC in the form of capital calls to fund the district's pro rata portion of the phase 1 construction's costs, not to exceed $17,674,794. Number 3, the Chief Executive Officer is hereby authorized to enter into any agreement or contract document necessary to carry out the intent of this resolution, and to take any and all further actions which in the determination of the Chief Executive Officer are necessary and proper to effectuate the intent of this resolution.
Thank you, Dr. Stewart. Do we have a second?
Second.
Second from Director Eapen. Any comments or questions? No? Very good. Cheryl, I'll call the question, and if we could have another roll call vote.
Director Nicholson,
Aye.
Director Yee,
Aye.
Director Stewart,
Aye.
Director Eapen,
Aye.
Director Wallace.
Aye.
Great. Thank you. Motion passes. Resolution 1226. Great work. Let's see it happen and look forward to 2024 when it opens.
Thank you very much
Yeah.
for that.
Great.
It's wonderful.
Well, you got a lot of work ahead of you. So
I know.
I know you've done a lot of work already, but
Yes.
still much ahead. So Kimberly, do you have any announcements?
I do have a couple of announcements, and I'm going to start with Employee of the Month. I do want to tell you a little bit about our May 2021 Employee of the Month, Angela Kahalavi. She's a registration staff person in the emergency department. For many community members who are experiencing a medical emergency, Angela is their first contact with Washington Hospital. She began her work as a per diem in the Washington Urgent Care Clinic in 2018. Angela enjoyed the work so very much that when offered the opportunity to move to a full-time role in the emergency department right before the move to the new pavilion, she happily accepted. Angela describes the emergency department as a phenomenal team of highly skilled medical professionals. She says, when things get stressful, we lean on one another. I know I'm surrounded by a group of people who provide excellent health care, who truly care about our patients and are able to adapt to emergencies quickly and effectively. Angela primarily works with patients who have been brought in by ambulance. She takes their information, answers many insurance questions, and listens to their concerns. She always exercises an awareness and respect of the cultural diversity of members of our community. And Angela was one of the first employees working in the Rapid Screening and Treatment Unit, or RSTU tent, making sure we had the health insurance information needed and sometimes dealing with challenging patients. She's a resident of Fremont and is happy to serve her community through her work at Washington Hospital. So I want to say congratulations to Angela. A couple of other announcements. I think you heard that it is National Nurses Week. It is also National Hospital Week, and that's the 9th through the 15th. And I do want to just extend my heartfelt appreciation to everyone, our physicians, our staff, and our volunteers, and everything that they have put into this last year. I know we reflected on sort of saying where this year, how far we've all come, but it's really the compassion and the resilience and the hard work of everyone throughout the healthcare system that has allowed us to really be able to meet the healthcare needs of our community when they've needed us the most. So I truly want to say thank you to everyone in regards to that. I also want to announce, given that it's been National Nurses Week, the 4 recipients of the Nurse of the Year Award. Our recipients of this prestigious Nurse of the Year Award are nominated by their peers for exemplary clinical skills, leadership, and professionalism. They illustrate extraordinary dedication to the hospital's mission and their patient-first ethic. The hospital's medical staff selected 4 deserving nurses from last year's pool of nominees to receive this award. And they are, the first is Shiny George. She is a critical care nurse. She's an RN, BSN, CCRN/CMC, and CNRN. Our next awardee is a preoperative holding area of the operating room and post-anesthesia care unit nurse, John Lazaro. He's an RN and BSN. Next is 6 West nurse, Cindy Chan, RN, MSN, CNSRN, CNEN. And then lastly, our oncology night shift nurse, Merlene Nurse. She's an RN, BSN, RN, BC, OCN. And so congratulations to everyone. And you can see those many certifications that our nursing staff has. I do just want to do a couple more announcements. I do want to say that our vaccine clinic has continued to be very busy. And as you know, it started as of February 1st. And as of this week, we've given 53,958 vaccinations, and 29,101 have been fully vaccinated. So our vaccination clinic continues to be very busy. Also, on Thursday, April 15th, as part of the Women Empowering Women Support Group series, Dr. Victoria Leapart, our gynecologist, presented Power of Meditation on Zoom. We had 17 community members attended virtually. On Tuesday, April 27th, Dr. Amrit Hansra, an interventional radiologist, presented Interventional Radiology for Vascular Disease on Facebook Live and YouTube. We had 84 community members participated in the live event, and since then, 305 additional people accessed the presentation. On Tuesday, May 11th, Dr. Mark Shu, a urologist, presented Enlarged Prostate Causes, Symptoms, and Treatment on Facebook Live and YouTube. We had 142 community members participate in the live event. And I just, any community members who wish to view, they can go to our website and see any of our education, and we have more coming up in this next month. Lastly, I do just want to mention, I know we, at the end of last week, we received numerous calls from from many concerned community members that they were hearing rumors about an increasing number of COVID-positive inpatient admissions to our hospital. And I do want to just say this is inaccurate information. We've continued to have below 10 inpatient COVID-positive patients in-house. And so I know that there was some concern about this. So we did put out a statement on our social media channels about it. And so just wanted to make sure that everybody knew that we were not experiencing an increase in COVID-19 patients. So wanted to mention it tonight. So, and we are continuing to vaccinate our community, and you probably heard today that the CDC did approve Pfizer to provide vaccination to children aged 12 to 15. And so those individuals living in the district is able to, starting tomorrow, to receive vaccinations here at Washington Hospital if they have a scheduled appointment. So, and that concludes my announcements for this evening.
Great. Thank you very much, Kimberly. Great choices on the Nurses of the Year. I really admire those folks. And it's so good to hear that our vaccination program can now be expanded to a younger population. That's the way we're going to get out of this situation. So really appreciate that.
Can I have a question?
Yeah, Mike.
Yeah. What's the vaccination supply like? And if we are getting more and more of the supply, are we to the point where we might be able to reach out to the school districts to try to promote or to make the awareness more prevalent? So.
Yeah, because I know that the school is really in terms of trying to get back into more of the in-person learning. So our supply has been slowly increasing, and so I think that is something that we can start to look at in terms of being able to reach out to the schools. And so that's something that we'll be looking at. We're sort of waiting to see, making sure things were approved this week by both the FDA and CDC, but I agree we can start to be in discussions with them to see how we can help.
So you think the with the Blue Shield access to vaccines is working as compared to the more limited supply at the county originally, or do you have any thoughts?
I think that, yeah, we're slowly increasing. It's not like we can get as much, we can't get as much as we always want, but it seems to be better now. And so, I think there's more available, and you're seeing that there's actually there's a lot more available in different sites, whether that's through, some of the mass vaccination sites, whether that's through the CVS's or Walgreens. There's just many more access points to vaccine now than there were previously. And so I think that's helping. And so I think there are a lot of places that you can either walk into or get an appointment, in 1 to 2 days. So I think that's helping a lot in terms of getting people that, need vaccinations. I think now it's trying to get to some of those populations that may have had some hesitancy or maybe more difficult to reach out to, that we really need to get to, because, I think some people may not easily be able to come to the hospital. So I think we've got to go to maybe some other populations and see how we can help.
Yeah, I agree.
There's still a significant population which is reluctant to receive the vaccine, and that's the hardest thing to overcome. So convincing those folks is going to be a big job.
Well, possibly when they see young children willing to get the vaccine, older people will say, "Well, it's not so bad." I don't know.
Yeah, well, Sometimes kids convince their parents to do the right thing.
That's right. That's what I'm talking about. Yeah.
Good. Thank you. Any other questions or comments?
The approval for teens is only for Pfizer, and Pfizer has got an issue with the cold chain operation because we kept in sub-zero temperatures. So getting these vaccines out into the field may not be that easy. But that's something definitely to be kept in mind.
I think that's true. We're also trying to partner with some of the pediatricians in the community too, and try to access the adolescents in that way. I know there's been some discussion about looking at that whole cold chain around Pfizer, and they're reevaluating it, but yes, that is still an issue. But I think it's going to be like Mr. Wallace said. I think we need to partner, whether it's the pediatricians or the school districts, and as more and more comes available, we'll be able to do that, I think, better.
Great, thank you. Any other questions or comments from the board members? Kimberly, do we have need of a closed session tonight?
We do not.
Thank you. Are there any other issues that the board would like to bring before itself? Not. Thank you very much. Great meeting tonight, and we will go ahead and adjourn. Thank you. Have a good evening. Have a great week.
Thank you.
Thank you.